I've already given a lecture in the intro to spine course on the biomechanics of the upper cervical spine, but this lecture includes movement limitations and hypothesis. This content in this lecture is foundational for the assessment of the subcranial spine. So you have to have a strong command of this content when assessing the subcranial spine, and also when treating the subcranial spine. All right, so we're going to go into the biomechanics of the upper cervical spine, and you're going to get repetition in addition to the lecture that we had last year. Okay, so if you look at the orthokinematics of the upper cervical spine, we've already discussed the upper cervical spine consistent of the articulation of the occipital condyles and the atlas, and also the articulation between the atlas and the axis. So we have the OA and the AA making up the subcranial spine. All right, so let's go through the forward nod. Sometimes we call that phenod. Okay, so with the forward nod, at the OA, there's a posterior glide of the occipital condyles on the atlas. With the forward nod, so this is forward nod, we refer to that as the phenod. So if you sit upright, sit erect, or stand erect, all right, the forward nod is just this movement right here. So it's like you're moving your chin slightly towards your mid-cervical spine or towards the chest. At the AA joint, the AA is the atlas on the axis. So the AA with the phenod, remember, the atlas follows the head with movement. The atlas follows the head. So with the forward nod, my head is moving where? Anteriorly, right? So the atlas is gliding anteriorly. Why is it important to know this? There you go, Self. So if any of these are an impairment or dysfunction, then as Self said, you know the mobilization technique that you should use to improve that movement. Good job, Self. So remember, I said this is foundational for examination and treatment. You must have a strong command of this. So this chart is going to help you. So you see the atlas is going to slide anteriorly. So I'm talking through this, and I'm taking my time talking through this because I want you to be able to command this and grasp this and wrap your head around this and go back and reflect on this and spend time with this. All right. The subcranial spine for most is difficult, but if you take your time with it, you got it. You take your time with it and command it, you got it. All right. Backwards nod. Backwards nod, just like so. All right. Probably about 0 to 15 degrees, somewhere in that range. Same thing for the forward nod, you know, without any deviation. Without any deviation to the right or to the left as the person tried to do it. Because remember, any type of deviation could be this type of dysfunction on one side or another. We'll talk about that later. All right, so with the backwards nod, you have the occipital condyles gliding anteriorly. All right, they have to glide anteriorly in order for that to occur. Why in the world do they glide anteriorly? What is dictating that? The convex on concave rule. So it's convex on concave, the glide or slide occurs in the opposite direction. So backwards nod, the occipital condyles have to glide anteriorly on the atlas. The atlas is gonna glide in which direction? Posteriorly, because it's following the head. So the atlas slides posteriorly. Let's recap. This is for nod. So you got a lateral view here. This is for nod. What are the occipital condyles doing? Gliding how? Which direction are they gliding in? Posteriorly. So that's for nod. This is backwards nodding. You can visualize this. You got to come in and play around with the skeleton. How are the occipital condyles gliding? Anteriorly. Good. The atlas is going posteriorly with the backwards nod. It's gliding posteriorly. And with the front nod, the atlas, you can kind of see it. It's minute, but you can kind of see it. The atlas is moving in what direction? It's sliding anteriorly, okay? It's minute on the model, but you can see it. We're gonna talk about rotation right and rotation left. So rotation right at the OA, there's gonna be a left anterior glide. So on the left OA, the left side, when I rotate to the right, so you visualize this, when I rotate to the right, so this is right rotation. What is happening of the occipital condyles with right rotation? How are they gliding on the left side? Anteriorly. How are they gliding on the right side? Posteriorly. That has to occur to achieve rotation right at the subcranial spine, at the OA. So the occipital condyle on the left side has to glide anteriorly, and the occipital condyle on the right side has to glide posteriorly. This is National Physical Therapy exam content. We got to command this, right? With rotation to the left, the right occipital condyle has to glide where? Anteriorly. And the left occipital condyle has to glide where? Posteriorly. Now at the AA, again, the atlas is going to follow the head. So at the AA, you get a left anterior glide of the atlas, and you get a right posterior glide of the atlas. Okay? Because the atlas is following the head. So I'm rotating, my head is rotating to the right. The atlas, the left side, is moving anteriorly, and the right side is moving posteriorly. You have to visualize that. So I'm rotating right, and you can visualize this. I'm rotating right. What is the atlas doing? So the atlas on the left is moving anteriorly. The atlas on the right is moving posteriorly. Okay? Come and play around. Come and grab Charlie. Grab Charlie so that you can visualize it and make it concrete in your memory. And then that makes it easier for you to recall this and retrieve this information when you're taking tests. With sliding, with right rotation, the atlas are going to rotate right and then slides left. So we talked about the gliding, so now sliding. So when we rotate to the right, the atlas is going to rotate to the right, but it slides to the left. So in order to achieve full rotation to the right, the atlas has to slide to the left. Notate that. Put a big star by that. You're gonna see that again on some type of exam in here, some type of quiz. You're gonna see it several times. If I rotate to the left, the atlas has to slide or glide to the right. Are there any questions about rotation right? And we just talking about orthokinematics now. Any questions about rotation right and rotation left? Yes.
Spot for the OA, when you put minimal, is that kind of giving us reference that we're going to treat the posterior glide because it's more significant with intervention, or it's just showing us movement there?
Okay, so that's a good question. So when it says minimum, meaning that it's likely that the severity of this is a low severity of that being the primary cause. So it may be minimum, it may be a minimum decrease. So what may be the major problem is this right here, the atlas sliding to the left may be your more bang for your intervention. It may be more of the cause. So what it may say is left anterior glide could likely be less of a cause. It could be major, but could likely be less of a cause. It could be more so of the atlas not sliding to the left. Okay, but you still screen it and check it. This is hypothetical, okay, because it could vary from individual to individual. Okay, but that's good observation. Good observation, Seth. These are the type of questions we need to be asking. We need to be inquisitive, you know. So it gives you a way to approach and think about things. It gives you a way to develop hypotheses. This is hypothetical, so we know to look at it, assess it, and see what's what with our patient. All right. So we covered forward nodding, we covered backwards nodding, we covered right rotation, we covered rotation left, or orthokinematics of the upper cervical spine. Now we're going to transition to side bending right and side bending left. All right. So now let's talk about side bending right and side bending left. We're going to talk about the OA. The OA is wet on wet. So occipital condyles moving on the atlas. What is the AA? Atlas moving on the atlas. We need to know this language, because when you're speaking and when you're talking and when you're doing your mobilization, you need to be able to verbalize to us what is moving on what. You need to be able to verbalize what is moving on what. So with side bending right, here we go. Side bending right, Tamian has already told us that the convex on concave rule is dictating our orthokinematics. So when we side bend to the right at the subcranial spine, what does the occipital condyles do? They slide in which direction? To the left. Good job. Because they have to slide in an opposite direction based on the concave convex rule or convex concave rule, however you want to say that. So with side bending right, we know, side bending right. So with side bending right, we know that the atlas follows the head. So which way is the atlas gonna slide? And you can see it here, it's minutely. I'm side bending right at the subcranial spine. Atlas is sliding where? To the right. I'm side bending to the left. Atlas is sliding where? To the left. Atlas is sliding left. Okay? So the atlas again is following the head. Now, here we go. Here goes the conundrum. All right? So, side bending right. I'm side bending right. Okay? With side bending right, subcranial spine. OA, I get a wedge. Occipital condyles move on the atlas. Occipital condyles slide in which direction? to the left. At the AA, I get the atlas with side being the right, sliding where? To the right. Now, with side being the right, which way does the atlas rotate or have to rotate? The atlas has to rotate to the opposite side. So with side bending to the right, the atlas slides to the right, but there's some minute rotation to the left. As it slides to the right, so picture it sliding to the right, it's very minute. As it slides to the right, some rotation left occurs. Some rotation left occurs. Okay? So when I side bend to the right, the atlas is sliding to the right, but some minute rotation to the left is occurring. That's why I'm taking time with this. I'm taking time with this. My GAs are recording this so you can go back and review this.
So is it wrong to say that it's slightly more anterior?
I'm gonna come back to that because I know what you're visualizing. I know what you're visualizing. What you're visualizing that as it slides to the right and rotates to the left, what you're visualizing is that the atlas on the right side is slightly moving anteriorly also, right? That's good visualization. That's good thinking. So in a sense, yes. Yes, because it has to. So what you've just done, what Tanya has just done is not on here, right? It's not on here. But what he has done is what we have to be able to do when we sit down and take written exams and when we're working with our patient. He did what we call extrapolate. He extrapolated from what he knew and he visualized. So, side bending left. Side bending left, we know what happens at OA. At AA, the atlas moves in which direction? It's gonna follow the head, it's sliding to the left. It's sliding to the left. All right? Now, which way is it rotating? To the right. Now, let's backtrack. Rotation to the left. Which way is the atlas sliding? To the right. Good job. Rotation to the left. The atlas has to slide where? Rotation to the right. The atlas has to slide where? To the left. Okay. Rotation to the left. Atlas has to slide to the right. Side bending to the right. Atlas has to rotate to the left. Side bending to the left. Atlas has to rotate where? To the right. In your orthopedic courses, you have to go put your hands on the Charlies. Because then you're going to be able to recall that content on the National Physical Therapy exam. Now we're going to discuss limitations and hypotheses. So this is important to understand this. So if you know the orthokinematics, then you can generate a hypothesis based off the limitations that your patients present with. Does that make sense? I'm going to say that again. So if you know the orthokinematics of the subcranial spine or any area of the spine, you can generate a hypothesis based on the limitations if you know the orthokinematics. You can generate a hypothesis of wet orthokinematic, wet intimate relationship, meaning glide or slide, the direction. You can generate a hypothesis of the direction that's limited. All right. So, subcranial spine. We talked about movement limitation with a nod. So movement limitation with Fernand, hypothesis 1 is OA posterior glide. Is that a legitimate hypothesis? So Andrew says yes. Now the question is, you gotta know the why to your yes. So why would you say, Andrew? Because of convex on concave rule. So we know that the occipital condyles have to glide posteriorly in order to achieve forward nodding at the subcranial spine. Let's go to hypothesis 2. All right. So hypothesis 2 restriction is an AA anterior glide of the atlas on the axis is limited. So that's a restriction that is hypothetical. Hypothesis 2 restriction, AA glide being limited. Jackson, is that legitimate?
Oh yeah,
Why?
because of the concave on convex.
Okay. So on concave on convex rule, good. In addition, the atlas moves in direction of where? The head. So we know it has to glide anteriorly. So the anterior atlas, the atlas gliding anteriorly can be a hypothetical restriction with limitation of a nod. Now, hypothesis 3 informs us to check the pelvic alignment, thoracolumbar spine, and forward head posture. Why is that? So if someone has a pelvic alignment that can work its way up the biomechanic chain, so there's going to be some type of malalignment or curvature of the thoracolumbar spine. So now what we're going to have is a compensatory strategy at the subcranial spine for someone to try to keep their head forward or to achieve movements such as forward nod in the sagittal plane.
So would it be excessive anterior of the pelvic to compensate to keep the head forward?
So that's a good question. So the pelvic alignment most likely is not going to be in the sagittal plane. The restriction is most likely going to be in the frontal plane. So most likely one side of the pelvis is going to be more highly elevated than the other side of the pelvis. Then it's going to work its way up the biomechanic chain up the spine. And what ultimately is going to happen is the OA at the subcranial spine, they are going to likely deviate one way or the other based on what's going on down here, and ultimately it can result in a limitation with forward nodding. Okay, because they're going to be biased. They're going to probably bias in a side bending. Okay, or they could be biased in a rotation. Okay, due to what's going on from the lumbopelvic hip region. Okay, but that's the third hypothesis. So they're just telling us to go down and screen the lumbopelvic hip region and the thoracic spine, because there could be something altering in that area. Okay, that's throwing them out of whack at the subcranial spine. Okay, so there's just extra information, that third hypothesis, extra content and knowledge for your information to know, to look at. If you can't find anything, if you can't find any restrictions with hypothesis 1, if you can't find any restrictions with hypothesis 2, then go to hypothesis 3 and check the pelvic alignment. You may find something there. Also with the forward head posture. Now the forward head posture is significant because the forward head posture, this is, now note this, write this down, this is on, this content is gonna come back at you. So with the forward head posture, the forward head posture puts the subcranial spine in what position? Flexion or extension? Extension. The forehead position, forehead posture puts the subcranial spine in a backward bent position. It puts the subcranial spine in backwards bending. All right, it puts the subcranial spine. Another word I could use is extension. But with the spine, I like to use forward bending, backwards bending, side bending right, side bending left. Okay, so I tend not to use extension in the spine. I tend to say backwards bending. Okay, all right. So if the forehead posture puts the subcranial spine in a backward bending position, what movement is going to be limited? Forward nodding. As you go back, you forehead posture, hypothesis 3, right? It puts the subcranial spine in a backward bent position, although it's like this, but the subcranial spine is backward bent or put an extension. So forehead posture is gonna limit forward noddings at the subcranial spine because now the subcranial spine is in a backward bent position. Well, where is the mid-cervical spine in with forehead posture? Flexion. Flex forward bent position. So make sure you know that. Okay? So with a forehead posture, mid-cervical spine, the person may likely lack backwards bending of the mid-cervical spine. Because forehead posture, mid-cervical spine flex, and you get somebody trying to backwards bend, that's hard to do. Put your head in a forehead position. Everybody put your head forehead position. Now try to do backwards bending at the mid-cervical spine. Try to backwards bend. Can you do it? Can you do it, Mason? It's tough, isn't it? Yeah, you cannot. All right? So good job. That'll help you remember that. So just think, all of these, hypothesis 3 goes back to this movement limitation. Hypothesis 2 goes back to this movement limitation. Does everybody see this? Hypothesis 1 goes back to this movement limitation at the subcranial spine. And same thing going down, all right? Each hypothesis goes back to the movement limitation as a hypothesis that could be limiting that motion. Now notice all of these are same as above for hypothesis 3, with forward nodding and backwards nodding. All right. With forward nodding with a right deviation. So I forward nod and deviate to the right. My chin deviates to the right. So I'm forward nodding, right? Forward nod, like so. This is what's happening. I'm doing this. My chin is deviating to the right with my forward nod. So my chin is deviating to the right with forward nodding. Hypothesis 1, there could be a restriction in OA left posterior glide. Now you gotta visualize this. With Charlie, I'm forward nodding. Now I'm forward nodding, but now my chin is deviating to the right. Okay? My chin is deviating to the right. So now my chin is deviating to the right because this left side won't posterior glide like how it's supposed to. So my left side is not posterior gliding. So what's happening is I'm deviating to the right. I got a deviation to the right due to a lack of left posterior glide of the OA joint. So you're gonna have to play around with Charlie to command this. All right, you're gonna have to come visualize it. All right. And now at the AA, there is a left anterior glide that could likely be limited at the AA for hypothesis 2 if I get a right deviation. So if I get a right deviation with forward nod, then my left anterior glide of the atlas could be restricted. All right, this is something you have to visualize. Forward nodding, if I get a left deviation, the right posterior glide of the OA could be restricted as my first hypothesis. And then the hypothesis 2, my right anterior glide of the AA could be restricted. So now what's this telling you with these hypotheses? You're gonna have to do what? You're gonna have to understand the orthokinematics. You're gonna have to come in and play around with Charlie and visualize it and go through it so many times so it can stick. So with backwards nodding, being the movement limitation, hypothesis 1 restriction is that there could be a restriction in the OA anterior glide. Hypothesis 2, there also could be an AA restriction with the posterior glide. So AA restriction with anterior glide, no, OA restriction with anterior glide, and an AA restriction with the posterior glide. Backwards nodding with right deviation. So I backwards nod and deviate to the right. So you see I'm deviating to the right. My chin is moving, deviating to the right with a backwards nod. Now, we have to be able to visualize and try to feel ourselves what is likely not happening for the reason of why I'm deviating and just not going straight back like so. So I'm just not doing a pure backwards nod in a sagittal plane. What limitation is taking me out of the sagittal plane with my backwards nodding at the subcranial spine? So I'm going here like so, I'm deviating to the right. So with the backward nod, so backward nod with right deviation. So I'm backwards nodding, deviating to the right. So OA, if I'm deviating to the right, OA, at OA, the right side has to be able to do an anterior glide as well. So if the anterior glide is restricted on the right and the left side continuously to anteriorly glide, if the left side continues to anterior glide, I'm gonna deviate to the right. Okay, so let's start there. So backward nodding with deviation to the right. So I'm backwards nodding, but I'm deviating to the right. So what's happening on the left side is continuing to go into anterior glide. But the right side is not gliding anteriorly, therefore we get the deviation to the right.
So if we are backward nodding, we're performing a backward bend in the subcranial spine, right? We know that at OA, we're rolling back but gliding anterior. Then when we get to C1 or Atlas, it's gonna glide posterior on C2. We all there, right? So maybe I'll do it with my hands here. So if I'm gliding posterior and I'm stuck on the left and I can't glide posterior, but I continue to glide posterior on the right, it's gonna pull my chin up. If this is my chin, it's gonna pull my chin up to the right. Okay? To the contrary, if my right side of AA, can y'all see? If the right side cannot glide backward or cannot go back, slide back as we backward nod, but the left continues to glide backward, and it's going to pull my chin up to the left. So with OA, okay, so look, you're facing, does it help to face me? Okay, so this is my face, below here my eyes, right? Okay, so if I am, let's say I am backward, or we want to talk backward bending or forward bending? Backward bending. So if I'm backward bending, okay, I'm backward nodding, what do my condyles have to do? Glide anterior. So if let's just say my left condyle will glide freely, but my right condyle will not glide freely, it's going to cause my chin to deviate to the right because I can't, right? Because the left side continued to go anterior, but the right side did not. So my chin will come up to the right. that help? Okay, so backward nodding, they should both glide freely anterior with OA. If they do not, and if let's say the left side is stuck and the right side continues to glide anterior, it's gonna bring the chin up to the left. Y'all see that?
What
Makes,
about a forward bend nod?
okay,
That'd be stop?
so forward bend nod, so if we forward bend it, you talking about OA?
Yes,
At OA, if we forward nod, what do the condyles have to do? Glide posterior. So let's say that my left condyle glides freely posterior, but my right condyle will not, okay? Which way am I gonna come toward? To the left, right? Because it's gliding posteriorly. You see that, Mason?
this one.
Okay? If my right side, if I'm forward nodding and my left side is stuck and my right condyle is freely gliding posteriorly, then I'm gonna deviate to the right. That's how it makes sense in my head, if that helps you to see that.
So let's recap, because I like to verbalize things myself to make sure I have it down. So you have to practice verbalization. So going back to backwards nodding with right deviation. So we already confirmed that the OA on the right, so backward nod, right deviation, we already confirmed that OA on the right is lacking an anterior glide, and the left side continues to glide anteriorly, and therefore we get the chin deviating to the right. So we got that. With the AA, I'm going to backwards nodding. I deviate again to the right. So what we have confirmed is that the left atlas on the atlas on the left does not glide posteriorly as it should, and because it's not gliding posteriorly, we get a deviation to the right. But the right side glides posteriorly. So the right side is moving posteriorly. And because the right side is moving posteriorly, the left side doesn't, therefore we deviate to the right. That would be the opposite for backwards nodding with left deviation. So I went ahead and changed that. So backwards nod, left deviation, the OA on the left side is lacking the anterior glide because I'm deviating to the left. So therefore I get the anterior glide on the right. The anterior glide on the right is occurring, it's happening. But on the left, it's stuck. So I don't get the anterior glide at the left. Therefore, as the right side continues to glide anteriorly, my chin deviates to the left, okay, at the OA. So backwards nodding, deviating to the left. At the AA, the right posterior glide of the atlas is not occurring. Therefore, since the right side of the atlas is not gliding posteriorly, now we get a deviation to the left because the left side is moving posteriorly. Left side is moving posteriorly, right side is not moving posteriorly. Therefore, we get a deviation to the left with the AA. So that's at the AA. So that's hypothesis 2. So side bending left. Here we go. Side bending left of the subcranial spine. We know that with side bending left, OA has to glide. Side bending right. We know with side bending right, the occipital condyles have to glide to the left. So we know that that could be a restriction. That's our hypothesis 1. Okay. Hypothesis 2, we know that the atlas moves with the head, it has to glide to the right. So the right glide of the atlas could be restricted. We know that. We know that with side bending to the right, the atlas has to rotate left, so that could be a possible restriction. That's part of hypothesis 2. All right. So vice versa for side bending left So side bend the right, side bend the left, vice versa. I'm not gonna go through both of those again. Rotation right. So moving on to rotation right. So rotation right. With rotation right, so I'm rotating to the right. So I know that OA on the left has to glide anteriorly, and I know that OA on the right has to glide posteriorly. So those could be possible restrictions as hypothesis one. So we'll be able to assess and treat those. Then we know, again, atlas follows the head, so rotating to the right, the atlas on the left has to be able to glide anteriorly, the atlas on the right has to be able to glide posteriorly. Those could be restrictions. And then we know also with rotation right, the atlas has to slide to the left. And so that's all within hypothesis two. So this is just basically orthokinematics at this point. Okay, understanding orthokinematics. With rotation to the left, you see I'm exaggerating. On the right side, occipital condyles, they have to be able to glide anteriorly. So therefore, the anterior glide on the right could be restricted with subcranial spine rotation to the left. The left side has to be able to glide posteriorly with rotation to the left. So the right side has to be able to glide posteriorly. No, sorry, the left side has to be able to glide posteriorly. So the left side has to move posteriorly, so that's hypothesis one. Again, rotation to the left, AA has to be able to, rotation to the left, the AA has to be able to glide posteriorly to the left, and atlas has to glide anteriorly to the right. So the atlas has to move to the right anteriorly, and left side moves posteriorly. And then, of course, the atlas slides or glides to the right with rotation to the left. So your hypothesis is based off of what? What are hypotheses based off of? Orthokinematics, concave convex rule dictates our hypothesis. So Kendall, being the studious student that she is, she went to Charlie and she tried to visualize and see how it could be what? Concave on convex of C1 on C2. The atlas and axis articulation. All right, so that is very, very good that you observed that. She tried to visualize it mentally in her head, and she tried to visualize it physically on the model. The articulation between C1 and C2 is convex on convex. And the rule for convex on convex is that the motion and the slide occur in the same direction. So the convex on convex rule takes on the same rule as concave on convex. The slide and glide I'm gonna say swing and roll occur in the same direction as the slide or glide. So that's a part of the reasoning for that. That's part of the reasoning for the atlas moving in the same direction as the head. Okay? Because you have convex on convex. Very good observation.